Welcome everyone as you gather for our second webinar for our Healthy Professional Worker Partnership, which is co-sponsored with the Canadian Health Workforce Network. So Kwei, bonjour, hello. I would first like to acknowledge territory. My name is Ivy Bourgeau. I'm the lead of both the Healthy Professional Worker Partnership and the Canadian Health Workforce Network. And I am coming to you from the unceded territory of the Algonquin Anishinaabe First Nation, and to whom we are grateful for the opportunity to live, work, and play. And if you can bear with me, I'd just like to say a few words in Algonquin. I've been taking lessons, so I'm pretty excited. Ivy Ijinis Kazan, Anita Ottawa Aki, Miigwech Kakanika. And so basically all I said is my name is Ivy and I live here in Ottawa, and to thank everybody. It's a very interesting language to learn. If you have any time, I would encourage it. So I want to just lead off with a little bit of information about the Healthy Professional Worker Partnership. Is a partnership grant that is co-funded by the Canadian Institute of Health Research and the Social Sciences and Humanities Research Council of Canada. We have 7 case studies, which includes medicine. And last month we had our presentation from our accounting group, so they kicked off our season. We have released our preliminary findings report. I will pop it into the chat so that you can have a look at it. And we will also be releasing today our infographic about the medicine case study. I'm really pleased to pass this over to Sarah to have the conversation today, which is really focused on interventions, which is the ultimate goal of our partnership, is to understand what the sources of stress causing mental health concerns and the pathway to leaves of absence and return to work, and how we might be able to intervene along that pathway to improve mental health, to improve, reduce presenteeism and burnout. And so I'm very excited at the conversation that we'll be having today. So I'll pass it over to Sarah, please.
Thanks very much, Ivy. And thanks to all of you for joining us here today for this conversation that promises to be very interesting and stimulating, and hopefully will leave us with lots of things to take back to our organizations and our work. I am the medicine case study lead for Healthy Professional Workers. And this is the webinar that we are hosting. We have decided to invite 3 experts to join us to talk about the respective roles of individual level and system level interventions to promote physician wellness. Today with us, we have Dr. Kim Kelly, who is an associate professor with the Department of Family Medicine at the University of Alberta, and the medical representative on the Diversity and Wellness portfolio at Alberta Health Services. We also have Dr. Simron Singh, who's a medical oncologist at Sunnybrook, an associate professor at the University of Toronto, the co-head of the Susan Leslie Clinic for Neuroendocrine Cancers, the head of Person-Centered Care for Cancer Care Ontario, and a member of the Ontario Medical Association Burnout Task Force. And we have Dr. Ed Spilg, who is a geriatrician at the Ottawa Hospital, a senior clinician investigator with the Ottawa Hospital Research Institute, an assistant professor and research chair in physician wellness at the Department of Medicine at the University of Ottawa. Welcome to all of our panelists and all of our guests. I'm going to start by going in turn to each of our panelists and asking each of you to tell us about your role in the health system and your perspective on physician wellness. And we'll use those comments as a foundation for our exploration of the question of the roles of individual level and system level interventions. So we'll start with you, Kim. would you like to go ahead and tell us about your role and your perspective?
Sure, and I'm just going to give the heads up that if I'm not unmuting, it's because my computer is doing weird things. So you may have to unmute me. So if I'm not talking, but it worked right now, so that's great. Hello, everyone. My pronouns are she, her. I'm Kim Kelly. I'm speaking today from Treaty 6 territory, as well as Métis Region 4. I identify as a cis-white first-generation physician, trained as a family physician, have worked in addiction medicine for 7 years, and have been in this role, a leadership role at Alberta Health Services in the diversity and wellness portfolio. The portfolio has existed for just over 2 years, and I've been in my role for 1 year. There's 4 of us total in the portfolio for the province, 3 physicians and 1 operational lead who may be on the call today. So the perspective I bring is really one of the importance of diversity, inclusion, and equity in wellness as well. And I love that our portfolio has both in the title, diversity and wellness. So it's really bringing together really the chief diversity officer and the chief wellness officer, and looking at wellness with both of those lenses. Also relevant, I feel, are that I lead the Equity in Medicine team, which is a national team of Canadian medical leaders across the country, and we're trying to advance EDI in the healthcare system. And also I founded the Edmonton Women in Health Network in 2019, and that was to fill a gap in Edmonton. There was really no place for women physicians and other healthcare professionals to come together, and I wanted to foster mentorship and sponsorship. And that has slowed down a bit with COVID. We're still meeting virtually, but prior to that, we were getting together in person, where organic relationships, support, empowerment could occur. So those are the lenses that I bring to the discussion today. Thank you.
Wonderful. Thank you so much, Kim. Simron, we're going to go to you for your role and your perspective.
Sure. So thank you very much. And I'm a medical oncologist at the University of Toronto at Sunnybrook, but I'm originally from Edmonton, and where I trained and grew up. So it's nice to meet you, Kim. I have a role at Cancer Care Ontario, which is now part of Ontario Health, which manages the cancer system in Ontario to some degree. This was a new portfolio created some years ago called Person-Centered Care. And really it was about trying to understand the patient experience, as well as trying to understand the quadruple aim and triple aim, which became the quadruple aim, which included provider experience. During my work there, as we tried to look at the patient experience, people going through cancer journeys, we recognized that some of the areas that we needed to improve upon was physician-patient communication. And then as we sort of delved deeper into this, we saw more and more that some of the challenge around communication was due to high degrees of burnout among our healthcare providers, physicians, non-physicians in the cancer system. And so we started to study on this to start to look at, to identify the problem of burnout among our cancer care providers in the province. And this was just before COVID. What we found was an alarming number of our physicians met standardized definitions of burnout. That was the Mass Like Burnout Inventory. 73% actually met those definitions of cancer physicians met. And we really align that with how can we provide good patient care and good patient experience when we have such a burnt out healthcare force. And then of course, this sort of started to develop my interest and our interest in looking in this area a bit more, and joined the OMA. The OMA basically identified from its membership 2 real priorities, and one of them was about burnout. It was simply about the wellness of its members across the province. So formed this burnout task force And then the third role is sort of newer, where at the Faculty of Medicine here at the University of Toronto, we built a wellness lead. And I really aligned with what Kim just said. We've actually strategically placed our wellness program at the University of Toronto for our faculty in a new division of diversity, culture, and inclusion, because we think that the ties are so incredibly strong, and there's such good data to show that a key component of wellness is inclusion and feeling that there's equity around you. And so we purposely did a very similar strategy as what Kim described. So those are sort of my roles. To answer the second part of your question about my perspective, from a physician perspective, I think traditionally, when we've talked about wellness, it's really been one of individual level wellness. It's been a lot about interventions. And I would even say wellness might have not been the right word. It was more about building resiliency. And that very quickly has now become a negative connotation, I think, in many healthcare providers' vocabulary, in that there's some resentment to an idea that healthcare providers should be more resilient or should be stronger and tougher, because it lays an area of blame upon the individual, saying that if you're struggling or if you're burnt out or if you're having problems, that this is a problem that you need to correct, which I think we all recognize, hopefully, is not necessarily the case. So I think my perspective is COVID has one of the very rare few things positive about COVID is it's brought this issue to the forefront. Maybe not for the reasons that I would have liked, but certainly the health human resource crisis has brought this to the forefront. So I think it's important that we start working together, looking at system level solutions, which isn't easy. It requires engagement of a lot of different stakeholders at a lot of different points along the progress to wellness. And I think the second point is we need to start thinking about culture and the culture of wellness. And like I can say, when we first brought up this idea at Cancer Care Ontario, and I talked about a burnout study, there was a lot of pushback. That's too negative. You can't be using those kind of words. You can't talk about burnout. You should be talking about joy in work, or you should be talking about wellness. And it still is quite a debate about how do you, the words matter and the culture matters, creating a culture of wellness. And that is a very active effort. It's not a passive effort. So those are my initial thoughts on this.
Wonderful. Thank you so much. And now I'm going to go to Dr. Ed Spilg. And Ed has a particular perspective on resilience and some expertise that hopefully we'll get to hear about more today. Ed?
Thanks, Sarah, and thank you for inviting me today to participate in this excellent discussion and webinar. So my background is I'm a geriatrician. I've been in practice for best part of about 30 years now. And for most of that time, I worked in the National Health Service in Scotland, Scotland's where I'm from, where I was trained, and where I practiced for a good part of my professional life. And while I was there, one of the areas I began to get involved in was supporting trainees who were in difficulty. And I had the role as an associate postgraduate dean in that field. And as I began to just explore this area, which is now we're looking at about 8 years ago or so, I began to understand that the whole research area in physician wellness was really quite an understudied area at that time. And one of the countries actually which has led from the beginning in terms of promoting research in physician wellness and just in physician wellness as a whole has been Canada. And so I was very lucky to be able to move here in 2015, where I was appointed as Vice Chair for Physician Wellness within the Department of Medicine here at the University of Ottawa. It was the first time that the department had appointed such a position. Prior to that, the department had positions of vice chairs for education, for research, for finance, and they didn't, and for clinical care. And it was only round about 2014 when they did a large piece of work trying to understand what it was that people in the faculty were concerned about. They began to realize that they really needed a dedicated position to focus on wellness, because wellness cuts across just about everything we do in the practice of medicine. And so I took on that role, and I worked in that role in 3 years. One of the key things I did was we built a physician mentorship program back, which we launched in 2016. It's still been running 5 years later, and it's growing from strength to strength. And that's something that I'm very proud of. And we're providing support to physicians across the department, and other departments have developed similar programs, and sometimes it's similar to ours, and sometimes they've used ours to modify theirs. But I felt increasingly that there's a need to study this in a more scholarly manner. So being a lead for wellness has lots of important roles, but one of the key aspects is being able to look at what's happening in the world. What does the literature say? What does the evidence say? It's something that's been deeply ingrained in me as a physician to practice evidence-based care. And I became, increasingly aware that we needed more research. We needed better research. We increasingly have tried to jump towards finding solutions to problems that I think we don't necessarily even understand what the problem is we're trying to solve. And I think that's potentially fraught with pitfalls, because we end up going down blind alleys. So part of my research focus has been to understand more about what is the problem that we're trying to solve. And it's only through inquiry, through various different techniques, using different quantitative and qualitative research methods, that I think we can better understand the problems and begin to be able to start to provide and develop interventions for which there is clear evidence that have been tried and studied and tested and understood, and have gathered from the literature evidence from other systematic and scoping reviews, that we can begin to understand how best to tackle this problem. So that's really what I've been doing and focusing on in the last 3 years, is predominantly a research role. And I've been working alongside wellness leads within my organization to support development of research, and also to bring a research lens to this to help guide some of this. The other, I think, relevant background for me is I did a master's in clinical leadership. It was a social science degree back at the University of Glasgow Business School 10 years ago. And that has helped me bring an organizational, be able to look at this issue from an organizational and behavioral lens, which I feel is quite helpful, something which I never really felt that I had from my medical training. So that's where I'm coming from in all of this. And it's great to be able to sit with such esteemed colleagues today to be able to try and unpick some of these issues.
Fantastic. We do indeed have a very high-powered panel. And now we're going to jump right into it and talk about, when it comes to promoting physician wellness, should we focus on individual level interventions or system level interventions? How should the interventions at these two levels articulate with one another? Where do you feel we should put our efforts? I'm going to leave this one open to the panel. Feel free to jump in, and then you can bounce off one another, bounce ideas off one another. Who would like to go first?
I'm happy to start. If
Great.
So I think this is a really important question, and I think we're starting to see a lot of progression on the ground in terms of this. So individual interventions, I guess I would think of them more as individual supports. We obviously got to remember to support the individual and to have those supports in place for individuals who are struggling or in distress or need that support. But that's going to be different from person to person. There's individual factors that are modifiable and non-modifiable. And then there's going to be some things that we can do to help understand the diversity of people that are providing healthcare. And that could be everything from traditional ways looking at diversity. But one thing, for example, we found during COVID was our early faculty really struggled, many of them, because of childcare issues. And some people who had older children, and when the schools shut down, it did not impact them on a personal level to the same degree. So many people are going through a similar storm, but just in a different boat. And so we need to allow, when we think about wellness, we need to allow that flexibility for the individual path that people are going through. In general, though, when the studies that we've done, at least, or looked at, really a lot of it is about system level burdens that are placed, that come down, that are not easily modifiable. So I think it's important that we make sure that we work together and bring together those people. As Dr. Spilg was saying, we need, like, the research, we need the idea, that we bring together people, and with those interventions are then measured on the impact on an individual level. So system of interventions that then get measured on the impact it has to an individual. I think that's really important.
Yeah, maybe I'll jump in. So in our portfolio, 4 people for the province, you have to look at, well, what's feasible with the resources you have. And so I really support what Dr. Singh has said, that on an individual level, it's quite unique. And what we've decided to do intentionally is focus on teams. So of course, there needs to be organizational priority given and senior leadership buy-in, but you can have quite a bit of effect on team culture and affecting the broader organizational culture. And we're targeting physician leaders in our portfolio. So building competencies, looking at the unique needs of teams, departments, giving them some autonomy to identify what makes them unique, what needs they have. And so I just bring in the team component there. And also as a physician leader, feeling that my responsibility is to keep pushing for system change, because it's difficult, it takes years, it takes resourcing. And so I feel that my role is to advocate for that, because I feel that's very difficult, and to continue building the partnerships. So tagging on to excellent work that's going on with other provincial organizations is really helpful and cost effective.
Yeah, these are, to sort of follow on from that, I guess, I mean, you've touched on probably one of the most controversial subjects when we talk about physician wellness, this interplay between individual and system level interventions, if you like, for addressing the wellness problem. Sometimes I find that that's a little bit, sometimes I find it can be too simplistic and unhelpful. Somebody once, wiser than me, once said that really we can't separate individuals from systems, because it is the individuals that create the organization and the systems within which we work. So as much as I think it's helpful to be able to look at it in terms of maybe some interventions, that when we talk about interventions which affect individuals, the way that these interventions not just affect individuals, but also change behaviors of individuals, which provides a sort of bottom-up organic approach to culture change within organizations, is critical. But also the way that when interventions impact on system change, then that the way that organizations interface with individuals in the way of managing change and organizational change and behaviors as well, especially when people are having so much fatigue at the moment from major organizational changes, This is a big problem. So, you know, within my organization in 2019, everybody was really, people were very stressed. We had a new electronic medical record. There was a major organizational change, and everybody went through a lot of stress, and many people suffered distress, and people thought this is about as bad as it can get. People didn't realize that within 6 months of introducing this electronic record, COVID was going to happen. And of course, when you look back at it, clearly what we've experienced with COVID-19 has been, you know, has just been, the enormity of it has been so much greater than anything I think most of us have experienced before. But it's another example that we just do not know what these stressors are going to be. The next stressor is going to be around the corner. So as much as I think it's helpful to be able to think about how we can address individual issues, how we can address organizational issues, I think we need to look at the fact that it's the same people in the same within the same organizations that we're trying to address. Another thing I just want to mention is when it talks about organizational and system changes, there's almost an implication in the discussion, in the sort of argument that there is a system that we're trying to strive towards achieving. I've got the benefit of having worked in the UK National Health Service and now the Canadian healthcare system, and they're both very, very different healthcare systems. And one of the challenges I find is people are trying to strive for the sort of optimal healthcare system. And the truth of the matter is such an optimal healthcare system I don't think exists anywhere in the world. So as Kim said, you know, trying to strive for system change when we don't even know how best to do that, what would be the optimal system in such a complex and ever-changing social, political, cultural, economic environment that we're working and living in just now, is really, really difficult. So there's only so many things we can control. We can control to some extent how we behave. We can control to some extent the work environments that we have to work in, but we can't really control directly governments and societies at the sort of micro level, but we can advocate, and clearly organizations like OMA, CMA and other organizations need to do so to push for that kind of change. But one of the things I advocate for is really trying to take the evidence for understanding what is it about individual interventions which make a difference? What is it that people can learn to do? Because we know at the end of the day that being able to understand and being able to deal and cope with major organizational stressors to some extent comes down to the way that we emotionally respond to situations in which we face. So we also know that teams are critical. We need to understand how teams can better be supported. We need to understand how culture can be changed within organizations to ensure that people feel safe to speak out. People don't feel stigmatized by coming forth and stating that, you know, admitting that they have mental health issues. Because at the end of the day, wellness isn't just about an organizational metric, which I'm concerned increasingly it's being seen as. It's about people, it's about mental health. At its most extreme, it's about mental illness, it's even about suicide, but it's also about the way that we deliver compassionate care to our patients and to ensuring that not only do we deliver high quality care, but we deliver care to our patients in a way that sits comfortably within our own professional expectations and our own moral and ethical values, such that we feel that at the end of the day, not only are we doing a good job with our patients, but we feel that we are living up to our own true values in the way that we deliver care to our patients and what they would expect from us.
Just want to add one thing about that would be that I think it's really important, however, you know, I totally agree that there are things that we can change, but the people affected don't necessarily aren't necessarily comforted by those things that, you know, we can't change those things in the system at the micro level, as I just mentioned. So I do think it's really important that we are very clear about what can be affected, what levers we have at an individual level, what levers we have at an institutional level, and acknowledge that changing things at a system level are difficult. But I think that's if we're going to actually move forward and actually do make a difference in wellness and burnout and improve lives, we have to sort of tackle those issues, which is very difficult. Multiple stakeholders, multiple agendas, bringing it together, very difficult. But that is really what makes a difference. And the risk is of not doing that is, I think, as we just mentioned, organizations, for example, appoint a chief wellness officer, but they don't really have the ability to move the needle or to make change, and that just frustrates people even more. And I would suggest it's probably if we don't give the proper policies, the proper tools to these individuals or these committees, that it's even better not to have one, because it's even more frustrating to have one and for it to be seen as tokenism.
And I was just going to add about really important point, I think, about there's no ideal solution and the evidence is coming. But as an advocate, my world as an advocate, I feel that we have to have action while we're waiting for research to tell us sometimes is what we're doing the right answer. So for instance, when I started the Women in Health Network, I didn't know that was the right answer. I didn't even know that was called an affinity group. Now I know that. And now I know that that's multi-pronged. One of the multi-pronged solutions is having affinity groups and organizations to inform leadership, but also to build culture, empower, support. So I think both are really necessary. And also, as we're putting things in action, definitely to have metrics and accountability to assess, is it working or not? But also realizing that some of the things we do are going to fail because we don't have the roadmap. We're discovering it at the same time that we're moving things forward.
Yeah, if I could just come in, I think I totally agree with you, Simron. I think there's a challenge here about taking people with us in this journey. And I've heard the same comments about resilience and how resilience has become a bit of a dirty word in this debate, because people do see resilience as a finger pointed at them, suggesting that in somehow or other physicians, or lack of resilience thereof in physicians, is somehow responsible for physician burnout, and therefore in some way it's almost assumed that the problem lies with the individual physicians, and therefore the solution lies within the individual physician, which we know is not the case. We have to take some responsibility, and we do always have to learn, and we have to work within the organizations. But it's not just even, I would say it's more than just about resilience now. I think I see increasingly burnout becoming a similar kind of term associated with sort of stigma and victimization and blame increasingly in the literature. And so one of the challenges, I think, is we don't really understand what we should really even be talking about, and should we, is wellness really the right term to be using here? Does it really capture the issue that we're trying to address? Burnout's a very negative term, and measures of burnout can be quite dichotomous or trichotomous depending on what scales you use. Does that really pick up the problem? And does that address some of the issues that people are facing at the moment during COVID-19? Has anything changed now? Because I think if we'd had this debate 2 years ago, this discussion 2 years ago, I think it would have been very, very different to what we'd probably have been discussing just now.
Yeah, I'd like to follow up on that. I'm really curious about, I've heard a lot about change, system level change, culture. I'm curious about, how do we measure that? How do we know that we're achieving change? How do we know that at the team level something is shifting, that things are better or worse. I'm wondering if you have any thoughts on that.
I think what, what part of that, I think the culture change is about people feeling comfortable talking to leadership and talking to those around, as we were saying about being comfortable to have these conversations. But I also think there's other metrics that we wouldn't necessarily think of, and those are related to diversity and inclusion and feeling that they're in an environment where they can be themselves and, and sort of obviously have a fruitful, fulfilling career within the framework of diversity and inclusion. And then the other piece I think that we've noticed, at least during COVID, is civility and professionalism. I think, I think the culture does reflect that. And I think it's a two-way street, obviously. When we give talks on wellness, everybody wants answers given to them. And we try to remind them that you're responsible for this culture as well. And civility and professionalism play a clear part of that. So I think those are different things we can look at that reflect the culture that we create when it comes to wellness.
Yeah, I really support measuring inclusion and looking at how to do that. Our organization is we haven't established metrics yet, but that's certainly something we're hoping to do in the new year. What are the metrics, right? And is it a combination of different metrics out there? We are going to be putting forward trauma-informed leadership in the new year, and we feel this is a way to tap into what all physicians have faced with COVID, and we feel that this might be a way to build compassionate leadership. So if you look at discrimination that some groups face, sexism, racism, ableism, etc., I think that's definitely something that COVID has brought to the table, is that everyone has experienced some degree of trauma and can be compassionate to colleagues, to their direct reports. So it's really, I think, fast-tracked our discussion and hopefully prioritize this.
Yeah, maybe I could just come in there and say that I think the narrative has changed. I think there's a number of drivers that have changed the narrative in the last couple of years. I think the equity and diversity has been a major factor, and the interplay between that whole field and physician wellness is now becoming increasingly intertwined and embedded as one issue, and it has to be, because one of the challenges we have with wellness is we tend to focus on the majority, but when we look beneath the surface, there aren't really that many majorities, because we're all a hybrid of so many different backgrounds and different features, that actually, although we think we're a very, very heterogeneous, very homogeneous group as physicians, we are amongst the most heterogeneous and diverse groups probably in any professional group, especially in Canada. So the other issue for me is the shift that I've seen happening from the narrative from what I think has been burnout predominantly as being the major outcome that we've been focusing on and measuring, to I think increasingly to what people are experiencing during the current pandemic, which from my own work is increasingly shifting towards studying and looking at moral distress amongst healthcare workers. And I'm not, the more I look at this, the more I wonder whether some of the studies and research into burnout that we're seeing carried out at the moment during the COVID-19 pandemic, whether that's, and I'm part of that, so I'm as guilty as many other people are for studying burnout just now, but I'm increasingly concerned that what I'm studying when I'm looking at burnout and what I'm measuring in terms of measures of burnout is not actually is not getting to the heart of the problem. We've moved with wellness issues, if you like, have been ramped up a whole multifold level now with the distress that physicians and other healthcare workers have been experiencing during the COVID-19 pandemic. It's unprecedented levels of moral distress. Moral distress, I don't think, a lot of physicians still struggle with understanding what they're experiencing is actually moral distress. They think it's something that's causing them a lot of stress, but they don't appreciate what it is. And I do feel that it's important that we start to look at that as a key metric at the moment, because if organizations don't start recognizing, if organizations don't recognize that we are seeing almost certainly unprecedented levels of moral distress within organizations, I worry that we're not going to be applying the appropriate interventions and supports and ways of managing these issues that we might otherwise miss if we simply focus on some of the other more traditional wellness issues, which have perhaps been espoused in a lot of the interventional literature up till now.
Okay, and how does gender and other diversity dimensions play into moral distress, burnout, wellness? Perspectives on that?
Yeah, the first thing I was going to say to that was I think we have to realize we haven't taken it into account until recently, right? COVID has really exposed the inequity that women have faced. I'm seeing less women applying for roles right now, which really scares me. That we were making some gains, and I'm worried we're going to have a big setback there. So first thing is taking into account and realizing we haven't been considering intersectionality, gender. We haven't put policy through gender-based analysis. So starting to do that with our policies, right? And using an equity lens and looking at our content and adding equity lens, inclusive lens, gender lens, I think is really important. So that's what I would start with.
And by content, do you mean medical school curricula, or are we talking about content of policy?
Yes, I was thinking of content of policy, content of education that we're offering physician leaders per se. So that's what I was applying.
I think the other two things to keep in mind when it comes to gender and wellness, one is, again, this idea about different circumstances and how it may affect people. And certainly, we know that everybody has different work-life balances and how they want to manage that. And so we need to allow flexibility for that, for young parents, for example, and other things. The other issue that's important is one of pay equity. And this is, been understood a little bit better now. Some good data has come out even in the last 6 months, at least here in Ontario, showing a gender pay gap where people are not getting paid for the same work. That certainly doesn't create a culture of professional fulfillment. And that needs to be addressed moving forward if we are going to be able to create a culture of wellness around us. You just can't do that when you have a gender pay gap that exists like it does in Ontario.
Great point.
I also was just going to mention safety at this point. So, as a basic need, having a safe environment is so important. And currently our reporting systems are lacking. and women who have faced harassment, women physicians who have faced harassment, can be in the system for years. And of course, that really affects wellness. And then, I think this leads to having our backup plans of, I think we assume that physicians are, the system's built that we're going to work at full capacity forever. And we don't take into account life events. We don't take into account births and deaths and even taking holidays often. So looking at these backup systems that should be in effect, I'm thinking to a day I went into the clinic and one of my patients had died from an overdose, and there was no backup plan. I just had to continue with my day, seeing all of my patients. So do we need a backup plan, more staffing, putting some of these processes in play ahead of time to meet the needs when adverse events, let's say, occur.
Yeah, that's a great question that we should all be asking ourselves is, what is the backup plan? How can we make a backup plan that works for everyone? There's a question in the chat about whether mental health is addressed in medical school. And as physicians enter the profession, are we prepared for the challenges that we might face personally and professionally? And so I would love to hear your perspective on this, especially as it relates to potentially encountering situations that could engender moral distress, how we prepare physicians to deal with that. That may not be completely unavoidable. So is it something that we need to teach our trainees how to deal with? What are your perspectives on that?
I'll maybe come in there first if I could. I mean, I think that's a great question. And, medical schools try and select people to the best of their abilities that they believe have the appropriate knowledge, skills, attitudes, behaviors to become a physician. And I think we've seen over the last 50 years significant changes in professional identities of cohorts that come in through medical school. And we've now got people, we've got people still practicing medicine who were in their 70s, 80s, and maybe one or two still in their 90s in Ontario and other parts of the country. And and we've got lots of young adults in their 20s. So we've got huge generational differences. And for me, there's no doubt that I talk to colleagues, and many people still talk about, in my day, I went through this is what I experienced, that kind of mindset. And most people believe to some extent that they were well trained for what they're about to experience. And we can't predict the future, but there's a few things that we can predict going forwards. And one of the things that I think we can predict is that the doctors of today and tomorrow are going to be facing even more uncertainty and are going to have to deal with greater and greater levels of uncertainty, and living with that and how that affects individuals on an emotional level and moral level is something that I do think we need to build into medical education and curricula at a very early stage for doctors for tomorrow. I think medical schools are doing a much better job than they were 5 or 10 years ago. And locally, I know that they're doing an amazing job. The amount of resources and time and supports in terms of, offering people wellness checks. They're really trying to destigmatize this whole notion. But I think there's a long way to go to really convince people that there isn't still a stigma around this. So I think we're making progress. I've seen great progress, but I think there's a lot of work still to be done in this area.
think to add to that, one would be, I agree, I think big progress in the last few years, but it's a two-way street. So, what happens is that, often there's this culture gap that's existing where these discussions are happening in medical school about work-life balance, and this idea of traditionally where medicine was more, you have to be a hero, and you would pride, you would say, I did a 36-hour shift without sleeping, and those things, that culture has to change. But it can't only change in the medical schools, because then you have the medical students then coming into practice and encountering a culture that's embedded that for many years. And we've seen some of that about this idea of, is this a Generation Z phenomena or millennial phenomena? And it really isn't about that. It is about changing the culture for everybody, but we have to make it, it's very tempting to get into an us versus them argument when that happens in medical school. So I think it has to translate to, the system has to be able to receive that message as well. And then the other thing is, I don't know the right word, but a lot of times physicians suffer from this idea that, and in a good and a bad way, that they're more important in the system that they are, that if they don't do it, nothing else will happen, or they're responsible and it's completely on them. And that's not obviously the case. The system works as a multi-cog system, and there's multiple factors involved. But sometimes we need to, I think what we do need to do is teach medical students that, you're one part of the system, and it's an important part of the system, obviously, but, not to say this idea that everything is on you and what you do is going to affect the outcome completely. It put too much pressure, I think, on doctors coming in for this idea that, whatever you do, you are the center of it, and that's, obviously has a number of side effects and outcomes.
Yeah, and I'll add that, but sometimes we are the only person, and so putting into place those backup plans are really important. I think role modeling is so important with our learners, and I would agree that things are improving on the medical school level of with the curriculum and talking about wellness, but there's still so much stigma around saying that you have mental illness as a physician, and the risk, or at least perceived risk, from doing so. Our system still rewards, overwork, and I think one of the solutions here is taking the decision away from the individual and having a plan. So, for instance, in the case I was mentioning of, you go into work and there's been an adverse event, ensuring that there is a plan, that physician knows, what, in this situation, you need to go home and take the day off, versus leaving it up to the physician to decide, because we're so used to feeling like everything else should come before us. So if we're able to put in some of these policies, procedures, etc., that will result in the physician taking care of themselves, and they don't have any control over that decision, I think that would help. And teaching our medical students and residents about limits, right? That it is okay to say no. And as you indicated, Dr. Singh, that realizing that we aren't the only person, things will still continue without us there, and being okay with that.
That's great. So we're touching upon some of the elements of a question that was asked in the chat about how we can implement flexible work arrangements that help to reduce the risk of burnout and promote wellness. And so I'm curious about how possible this is for organizations to adapt these solutions, especially when everybody is stretched in the context of a pandemic and all in a system that already works in a very sort of lean way. Any comments on how we can make this work?
I'll maybe, start off by saying, I think there are examples of different systems around the country that you could speak to people and find out how people have addressed these issues. I think, the manpower issues or person power issues is a big problem at the moment. We just don't have the people to back us up. We do feel as physicians, sometimes we're our own worst enemy. We do sometimes feel we are invincible, and we sometimes have difficulty shrugging off that idea that somehow or other we must, the system is totally dependent on us and we will never fail and we will never fall, because if we have that attitude, we will fail and we will fall. I'm a firm believer when it comes to finding solutions to problems is to find solutions that other people have done that work. The chances are, if someone else has got a solution that works and they've got a system that works similar to yours, then applying that model to your system will probably work too, or at least it will work with some modifications. Where it becomes more challenging is when you go around and you talk to colleagues around the country and wellness leads and other people who run organizations and say, have you managed to crack this problem yet? And they say, no, we haven't cracked this problem yet. And to me, that makes it more challenging, because how do you fix a problem that other people haven't necessarily fixed? Because no one individual is necessarily going to be able to do that. So, I would say, find the problem, see if someone else has addressed the problem, and if they have, try and apply that solution to your own setting. I'm not an expert in solving this issue, but I'm sure that there are organizations that have gone some way to help address this.
I would add to talk to the people. So often we're not hearing certain voices, right? So let's say young women who've had children. Do we hear from them much? Not really, because they're not represented in leadership. So that voice is often missing. So I think it's really being aware of what voices are we missing, and taking it again to the team level. And teams can be very creative and innovative with solutions. But realizing that people do want flexibility, and there's different ways to achieve that. And if a team comes together and talks about it, and not just the physician part of the team, but all people in the team can contribute to solutions.
Wonderful. Now, recognizing that we're approaching the end of the webinar, we have a couple of minutes left, and I'm going to give each of you a magic wand and the opportunity to wave it and change one thing that you think would make things better for physicians. You want to start, Dr. Singh?
Sure. Okay. I had one thing better. I think one of the struggles I see is, and this is a very specific example, but is the increasing complexity of our healthcare system leads to a lot of extra administrative work that has landed on the plates of physicians. And that's A, not compensated, and B, it is not necessarily value added to either the provider or most importantly to the patient. So I think a cause of that is, the way that we compensate physicians is sort of siloed, so that not necessarily for example, in a hospital, physicians in a hospital like myself, the hospital doesn't necessarily care if the physician is doing this work, because they're not actually paying for that work, right? And so there's this disconnect. So I would like to see greater integration of that work within the healthcare system to sort of streamline some of that extra non-value added work that could be taken off, which would, I think, help patients, improve patient experience, but also increase professional fulfillment.
Excellent. Dr. Kelly, 30-second magic wand.
What brought me into leadership was the lack of childcare. So my magic wand would be a childcare solution for all healthcare workers. It doesn't have to be on site, but 24/7 ability to have childcare, emergency childcare would really, really be a game changer.
Excellent. Dr. Spilg.
30 seconds, magic wand. I think I have to put my magic wand, you know, I have to look beyond, I can't look at the 5-10 year future. I need to look at now. My magic wand now needs to be, how do we address the severe levels of distress which healthcare workers are facing? And if I had a pot of money, if I had resources, I would really be saying to organizations, we need to be doing more to better support workers within the organizations, cope with severe levels of emotional and moral distress that they're currently facing. Because if we don't, there's going to be this buildup of moral residue that's going to come back, and it's going to drive burnout in a way that I don't think we've seen burnout driven up till now. Totally agree with everything Dr. Singh said, but you've got all of that plus everything that COVID has added into it. And we've got to address the COVID problem, because that's the here and now.
Excellent. Well, I'd like to extend very sincere thanks to Dr. Kim Kelly, Dr. Ed Spilg, and Dr. Simron Singh for joining us today for a very interesting and engaging discussion about all of these problems that are facing us, and hopefully we can all take them back and work towards making things better. Ivy?
Thanks so much, Sarah, for moderating. And again, thanks to our panel. We just want to wish everybody a happy holidays. Take time if you can. If you'd like to download the chat, you can just click on the 3 little dots. And our next Healthy Professional Worker webinar will be in January, led by our nursing team. And our next Canadian Health Workforce Network webinar will be focused on a vision for a health workforce agency in Canada. So I'd be pleased if you could join us. Thank you, everybody. Really appreciate it.